This video was focusing on how we perform the modified Mason-Allen suture. We have performed management for the rest pathology we found in this patient, which are subacromial compression, bursectomy, debridement, and subscapularis tendon repair. This is the disclosure of this video of technical notes. First, the torn supraspinatus was debrided and mobilized to its original insertion. The bone was resurfaced by a severe debridement of the antithesis of this supraspinatus footprint. Then we took care of the anchor insertion at 45-degree angle into the proximal humerus to increase its resistance to pull out. The tunnel was made in the medial row, firstly at the anterior aspect. Then the double-loaded suture using Y-knot RC 2.8 mm conmat were inserted in the medial row at the junction between the articular cartilage and the row surface of the supraspinatus footprint. And then the second anchor was placed posteriorly with bridge distance 2 to 3 cm from the anterior anchor. A solid colored thread from the anterior anchor was penetrated using through pass, creating the first passage from the interarticular side to the bursal side. Then the first passage was placed anterior to the musculotendinosis at 0.8 cm to 1.2 cm from the tear edge. Then the second solid colored thread was similarly passed with through pass suture passer, creating the second passage in the musculotendinosis. Then penetration was made with Akupa suture passer 1.5 cm to 1 cm to the first and second passage, taking both the tiger colored thread from the first anchor through the third passage. A solid colored thread from the second anchor were also passed, which creates the fourth passage, which was placed 1 cm behind the second passage, and the fifth passage was created 1 cm behind the fourth passage for the remaining solid colored thread. Tiger colored thread from the second anchor was penetrated in similar manner to the first pair of threads of the first anchor, which creates sixth passage. Then solid color sutures from the second anchor was noted. Then knot tying was also done to the suture in the first and second passage. The torn musculotendinosis rotator cuff after mattress sutures was approximated, but a gap of the two between there. Then one thread from the third passage and one thread from the sixth passage was brought into the lateral row in front of the sulcus bicipitalis and to be fixed using the multi-fix anchor by Smith and Nephew. Then for the remaining thread was taken to the front of infraspinatus, similarly fixated with the knotless anchor by pop lock 4.5 by conmat. Then the double row suture bridge was then created, removing the gap between the torn musculotendinosis rotator cuff and the footprint. In conclusion, there are few pearls and pitfalls to these procedures. From the steps of the procedures, a few complications may arise, such as neurovascular complication, overtension from the ripstop, and strength reassessment may lead to strangulation and re-tear. However, if done with precision, this modified Mason-Allen procedure using double row suture technique allow better attachment and approximation of the torn rotator cuff to its footprint, with excellent ripstop from the horizontal mattress suture.